Simons Searchlight is an online research rare disease registry. We collect medical information through high quality, standardized natural history surveys. And we have five main goals that we're highlighting here. The most important pieces that I want everyone to walk away with from today really is point 1 and 3. So first of all, we spend the majority of our time collecting medical history information, cleaning that data, also getting the behavioral information and the blood samples from families worldwide. We do give this information back to families, so I'll talk about more specifically how in the few ways that we give information back. But the other really important piece that we have here is that we share this information de-identified to researchers worldwide. And so we are not trying to create any silos or a barrier to access, and we want to amplify the number of hands this data gets into. We also have a method to connect researchers to participants. So that's through a process that we call research match. So if there are researchers in the room who want to recruit from the MED13L community, other communities, either locally or by genetic variant or any other criteria, we are able to assist them with that. That's also free. And then ultimately, we want to bring awareness to these rare genetic communities through publications, presentations, and other scientific efforts. So I truly apologize. Some of the images I looked afterwards that are blurry in a larger view. But the point of this slide is that we study many neurodevelopmental genetic conditions. MED13L has been on our list for quite some time, I think from about 2018 or so. And participants can register with a genetic diagnosis with MED13L in English, German, Spanish, French, Italian, Dutch, and Portuguese at this time. So we recognize that rare genetic communities need to have like a global concerted effort to really get a good understanding and get as many people as possible participating in research. What we collect is shown here as a highlight of what we currently are collecting. So in the past, some of the different surveys were included and the research study was a bit more in person and so forth. Our study has been going on for 15 years as of this year, but this is what we currently have available. For the families in the room, we have several surveys that we ask at what we call baseline, or this first time point that you interact with our registry. There's some medical features and questions that change over time as a person develops and grows, or just from year to year, these changes might happen. So you can see what we ask about annually as well. But we ask across the spectrum, including a genetics lab report at the very beginning that helps unlock participation, and then a medical history that encompasses all body systems, seizures, sleep. We want to know quality of life for the family. We want to know social, behavioral questions and communication questions. So we are asking across the spectrum, and we're always reevaluating like what is the best way to assess a particular medical feature, and we're always working on upcoming measures to include within our registry as well. Okay, so the information we give back is in a few different places, but the most obvious is that we do these presentations at different conferences, scientific and family conferences. We provide summary snapshots. So we do a quarterly report or a summary snapshot about every 3 months. And this is available publicly on our website. So if you go to the MED13L page for our Simons Searchlight website, at the very top, you'll see our most recent registry report. If you scroll to the bottom of the page, we have other registry reports that we've ever created. And often what we'll do is we'll do a general highlight of as to how many people is this report including and what are the medical features within that community, as well as a survey highlight. So one of the last registry reports we did was an update on the Vineland-3, which is adaptive behavioral survey. I'll be showing some of that data upcoming. That's one of the survey data I'm showing today. But we also have the summarized data available publicly on our website. So people do not need to be Searchlight participants in order to get access to this information. And often what people do is they bring these summary snapshots and so forth to their school, therapists, doctors, and anyone who might want to learn more about the genetic condition. And we know this because we've had people email us and say, tell us more about this, what's going on, tell us more about this data, this registry, and so forth from experts around the world. So we definitely try to make this resource as lay-friendly as possible for the families to be useful, but as comprehensive as possible so that the doctors and everyone who might want to learn more have their answers sort of their questions answered. And then finally, the bullet points are in opposite order, but we also provide personalized reports. So for participants within our registry, we provide some personalized reporting for certain surveys. So if you complete a seizure history survey within our registry, we are able to generate a report for you for where your answers lie within the MED13L community. So you can kind of see, are you within the average or are you an outlier? And that is only for the participants who've provided data as a way to have access to where their answers kind of fall within the community. Um, Before I get to the more Simons Searchlight data, I wanted to highlight that the data is being used. So this is a summary of within the last few years where MED13L data has been published across different research groups, as well as some research that I myself have completed on the data. We also have recruitment efforts that have included MED13L participants. So these are other research groups and publications and thesi for master's students that have recruited from the MED13L community. So it is another way for participants to find other researchers, and then researchers, please definitely feel free to contact us and use us to help with recruitment for other research studies that you might want to include MED13L families. So this is just my quick plug again for the researchers in the room and for families to understand how quick and easy the process really is. The researchers do create an account within our database that we have all the data included. So that's Safari Base, and the website is base.safari.org. It takes a few minutes for the researchers to say, I am with an industry, I am with an organization, I am with a university. Who are you with? Pharma and industry partners are able to access our data and biospecimens no problem, as well as academic institutions. It takes about 10 minutes or so to walk through the steps of saying who's going to use the data, what is going to be done with the data, and what data or samples would you like. So just making it's almost like creating like a shopping cart, selecting what we have within our system, and letting us know for safety purposes who's going to be using the data, and promising there's a paperwork step that promises you won't be re-identifying families and so forth. It takes a few weeks for our team to review the requests. Most requests are approved, and if they don't get approved, it's usually because that we don't have data for that community or a paperwork step was missing. So in general, we're not trying to create barriers. So now to highlight the MED13L registry participant information within Simons Searchlight. These are for families that have participated. These are the different steps that you likely are familiar with, starting with at the left, signing up online. This can be done by anybody. So although the number is quite high, we consider the real participation number at the step where we've approved a genetics lab report. So we've reviewed the genetics information and we see, yes, this is a variant of uncertain significant, likely pathogenic or pathogenic diagnosis that we're able to open up and pass the person through to the next steps, which is the survey collection. We have medical history and other surveys available at the same time. But we pull out medical history. So we have 103 families that have shared medical history with us. We pull this out as a really important data point because it has such rich amount of information and body systems covered, and often researchers really look to this resource to understand and write up about the genetic condition. And then some of the other surveys, we actually have more participants. Some of the surveys are much faster to fill out. So we will acknowledge that the medical history can take quite some time. We have 34 blood samples from families within our system. And then we follow up, as mentioned, over time. We're longitudinal. This study is longitudinal. Here, I'm now showing the genetic variants of families that are pathogenic and likely pathogenic for MED13L. So we have 123 families shown here. Some variants are not shown. So we have some deletions of the MED13L gene that are quite large, or within the gene that are not being shown. So that's 25 people with a deletion. We have 10 splice site or intronic variants that we're not showing. And then, as mentioned, not showing the variants of uncertain significance. So the rest of the talk actually will be focusing on the pathogenic or likely pathogenic variants. This is just to say that we know that these genetic variants, these genetic changes, are associated with the neurodevelopmental condition. And so we have the variants of uncertain significance within our registry, and researchers can access this data. But when we do data summaries, we just want to be really confident that the medical features that we're describing are associated with the genetic condition and not potentially a different genetic condition. So as you can appreciate, and likely as what is very well known within the MED13L community, is that the genetic variants are quite unique in general. They span across the MED13L gene. We do have some people, so you can see this here. We've noted 2 people here, 2 people here, 2 people here. We've noted when there's more than one person with the same variant. Not every time are they genetically related, meaning not every time are they siblings. We do have some people in our registry that are independent, coming from different families that actually do have the same genetic variation. And it's just a handful of times, and we're just noting that here within this variant slide. Now, where our families are located is highlighted here on this map. So Simons Searchlight in general have 83 countries represented within our database. That's shown in the blue. So in the blue, you can see that where our Simons Searchlight families in general, who is participating where. The MED13L families in particular are shown in the yellow sort of bubbles. So we have a large community in North America, as well as our next largest community in Europe. And now for the biological specimens, the next 2 slides, I'll be talking about in general what we have available, and the iPSCs in particular, the induced pluripotent stem cells that we have available. So we have, when we collect the blood, we collect 2 different tubes, and one of them is to create cell lines. And so we have these, the sample type from the blood that we call PBMCs, that are currently not distributed to interested researchers, but we are working on opening this up. So if other researchers, if we're not able to make a cell line, that doesn't mean that that sample is not available. That's upcoming in the next few months from our same Safari-based system, where interested researchers can see the menu of any genetic variants that are there for a genetic community, and they'll say, I want to create iPSCs from this. then we'll make those available for the researchers. As of right now, as of the time of these slides, this is not the case, but we are working on it. So we have created 6 cell lines that are currently being distributed. And then the other blood tube type that we currently collect is to have whole cell blood DNA. So we have 30 samples from families right here. We used to collect saliva samples from international families that couldn't contribute. So we have 6 samples additionally available here. And then we've created also in the past some other types of cell lines that are available. We don't have a system right now of collecting more saliva DNA or making more of these lymphoblastoid cell lines or LCLs. But they are available for the MED13L community. So in total, we have 46 samples available for researchers to request right now. If you're wondering what cell lines in particular that we have, these iPSCs, here are the 6 cell lines that we have right now for MED13L. 4 researchers have, 4 different research groups have requested cell lines to date. And then we tried to create an additional 5. They did fail. This is for a combination of reasons, but some of them had multiple attempts and we were not able to create those cell lines. So we just wanted to show here some of the other cell lines we did attempt to create to have a more well-rounded inclusion of some deletion cell lines and across the range of the gene, these loss of function variants, but these are just the ones that we have available at this time. Researchers are able to request these cell lines, so data is always free. The cell lines always come with a small cost of $124 per sample. This is not meant to be, a prohibitory or a big barrier for researchers. It is just to help maintain the repository. And then the researchers also have to pay the cost of shipping and handling. That seems to be usually where the high cost is for researchers, unfortunately, depending on where the cell lines are going. But in general, we've funded the creation, quality control, and all the other necessary processes for these lines already. So now to the first survey data that I'll cover. So I will cover now 3 different survey data, so 3 different surveys within our system and some information from those surveys. You'll see that the numbers will change for each of those surveys because it really depends on how many people filled out that particular survey. So I'll try to make it very clear how many people for each of the different surveys that will be covered. But here in general, you can see the age range of people we have within our registry. For the 79 people with likely pathogenic variants, we have an age range. Most people under the age of 18. We do have someone as old as 33 participating, and the average age is 9 years old, with a good spread between male and female participants. So now for the developmental and behavioral concerns, we have the most often reported medical features being intellectual disability and language delay and impairment. So almost 100% of people have both of those medical features. We have 28 people with autism. We have 10 people with ADHD and anxiety, and 6 people with reporting obsessive compulsive disorder diagnosis. For the other medical features, this is a summary slide showing how many people we have saying, yes, I have something within this body system. In the next few slides, I'm going to cover more details. So what type of neurological features, what type of vision issues, and so forth. So here it is and I won't cover every single one, but the majority of them. And here's where you can see how many in general are describing the type of medical features here within our medical history. So 72 people, 91%, have issues with neurological development, and we'll talk about what is within that category in that upcoming slide. 62 people with vision, so very common with vision and gastrointestinal issues. Almost half, or about 40% of people have endocrinological issues. About 1 in 3 have orthopedic issues, specifically highlighting tibial torsion, but we'll again come to more specifics in the next few slides. 20 people have reported having a heart finding. We have 18 people with genital findings, but most often undescended testicles. I won't be going into detail for the genital issues. That is, for the most part, what we're seeing. We'll cover several slides on seizures and seizure medication. So 14 people out of the 79 people have reported seizures. And then much less often seen are some joint problems such as hypermobile or overly flexible joints, kidney issues, immune issues or autoimmune issues, gastrostructural findings, or structural birth defects. So within our system, within our research, that's what we're seeing. So now for neurological, likely, I will say the families are not surprised with a lot of the information. Low muscle tone is the highest reported medical feature. So that's also called hypotonia. And then the other reported neurological medical findings often are to do with movement. So we have coordination issues, movement disorders such as ataxia, dystonia, tremors, and cerebral palsy. So it really has to do a lot with the movement. And then we also have just 3 people with cortical visual impairment, or CVI, sometimes called, and then smaller than average head size, which is also called microcephaly. And only 1 person needed surgery in this area for tether cord release. So that can be trapped in the spinal column, and then the cord needed to be released by surgery. Now for the seizures, and I'll talk about medications further on in the presentation. But now for seizures, out of the 79 people, 14 people have said that they've had some sort of seizure type. This is excluding febrile seizures, so seizures only related to do with, or only usually linked to fever or high temperature. It's also excluding people that only ever said that they had an abnormal EEG, but no seizure diagnosis. So in general, the average age of seizures within our research registry is being reported around 6 years. And then what we see is that the seizure onset is anywhere from 3 months within the community to 18 years. So it's quite spread across the research cohort. We have about half of people, or just over half of people, ever reporting taking seizure medications. And the 11 have reported needing to continue to take preventative medication. So about 3 were able to take it and stop needing it, maybe growing out of seizures or the seizure condition subsiding. We have 10 that report seizure control with the medication or remission. So 10 out of 14 report that they're able to control the seizures with medication, or it is in remission. And then control is reported. So the age range for control is usually around the age of 8 on average within their data. But age range for control is anywhere from 8 months to 18 years, so quite spread across the community as well. Now for vision issues. Vision issues spread across the ability to see farsighted, crossed eyes, or astigmatism. Those are the most common. And many of those people, about 17, had a surgery to help improve vision. Less often, medical features are like a cataract or coloboma, depth perception issues, glaucoma, and ptosis, which is the droopiness of the eyes. And so it is quite common, but in general, these are the top 3 within the 79 people that we have within our research registry. For endocrinological, so hormone issues, most often what we're just seeing is the short stature being reported, 17 people out of the 79, or failure to thrive. So these are the most common, much less common, much more spread out in terms of puberty. So 2 people have reported early puberty before the age of 8, and 1 person reporting later puberty. So maybe as our research community continues to grow and hopefully participants continue to participate as they reach more into the puberty ages, we'll have a better idea because our cohort, as we mentioned, is average age of 9, or many people under the age of puberty. We might not have a really good sense as to what is going on within this group. But in general, for now, it seems like the puberty is not popping up in terms of research findings that we're seeing. For orthopedic issues, so challenges with bone growth, development, or function, for the most part, we're seeing tibial torsion. This is essentially the pigeon toeing or in toeing of the feet. So people saying that they're dependent or they themselves are walking with their toes pointed inwards. That's what you're seeing with the 16 people, the 20% of our 79. Here you're seeing again tendon release reported. And then some other findings that we're seeing is the pronated feet, so rotated in, falling inwards feet, scoliosis in 5 people, so the curvature of the spine. The pexis excavatum, we're seeing 3 people, which is the sunken chest inwards. Another curvature of the spine in a different direction, the kyphosis, and then the hip dysplasia, the hips not sitting properly in 1 person. For heart issues, so 20 people in our research registry reported heart issues or a heart finding. And this is true. What I'm about to say is true actually for all the data, is that someone could click more than one of these features. So what I'm not showing is an individual person who had both atrial septal defect potentially and a dilation. So it could be that someone has more than one of any of the body systems that we're showing. But out of the 20 people, we're not seeing so much that there's one heart structure finding that is popping up within the community. It's quite spread out. But atrial septal defect seems to be the most common within this particular community. Only 4 people have required a surgery to help with the heart structure finding. And in general, yes, quite spread across. And here are some of the other heart issues that were typed in the other findings. So these are categories listed here that we have set within our medical history. And then here is where people have typed in the extra other findings that they've had. Now, another common finding which is the gastrointestinal issues, which is again likely not surprising to the community. Most often constipation and the gastro reflux, the GERD, where there's reflux coming in through the esophagus. Those are the 2 most common. Less often we have the diarrhea being reported. And then there is some hernias. So about 11 people have had hernias. And 5 people in total have required some sort of surgery to help with feeding. So the nasal gastral tube or J tube to help with feeding. But again, quite spread across the community for the other gastrointestinal findings that we have, and the other issues that were being typed in as well. I should always mention, sorry, that whenever there's an other, as I said in the last slide, these are other findings that people are saying that we're not routinely catching, but we definitely record everything that families type in and let us know what's going on within our medical history. So additional surgeries not yet shown, and I'm coming to the end of this medical history data, but additional surgeries not yet shown most often, and I would say this is very common within Simons Searchlight in general across our neurodevelopmental community, is the adenoids removal, tonsil removal, and PE tubes, the ear tubes that happen either from chronic ear infections or challenges with hearing. These are the most common, tonsils kind of falling in with the adenoids, but these 2 are the most common within the MED13L community. And then across some other surgeries that have been reported, which is the tongue tie craniofacial challenges, so the craniostenostosis, when the bones start to fuse too early, so needing a release of those bones, and a cleft palate, cleft repair. For medications, and I'll cover surgeries on the next slide, for what medications are being taken within the community, sleep. So sleep challenges do happen within MED13L neurodevelopmental syndrome. We do have some people on a sleep medication. We have several people needing help, as noted, with the constipation, having gastrointestinal challenges. And then we also have some people on antidepressants, medications for pain, and medications for severe mood and behavior. The issue to note here is that we're summarizing medication use. So only 60 people out of the 79 have ever taken any medication. But the issue to note here is that some medications can be used for more than one medical finding or medical feature. So we're categorizing them for the indication of the medication, but they might be used for something else. We do record and we do ask what families are using the medications for, what's the secondary use, what's the other uses, and so we have that information available to researchers if they're interested. For seizure medications, this is a frequent question as to what is most effective. We ask the families what medications are using and what is most effective. It's challenging. We're not seeing one medication really come out of, so out of the 14 people who had seizures, and I believe it was 11 that was reporting taking medication, we have effectiveness of medication from 8 of them. And you can see it really isn't one medication that's popping up as super effective. This Keppra is the I'm terrible with medication names, levetiracetam. But that's still 4 out of the 8. It doesn't have a good, it's not a good spread across everyone as the one medication. It might work better for a period of time. So this is also something that does change in the community over time. So we're just sharing what the families have said has been most effective, but it still is very much individual based on their needs and seizure presentation. So now for the second survey data that I'll be covering, it's called the Vineland Adaptive Behavioral Scales. We use the Vineland 3. It's the version of the Vineland that we have within our system currently. This is parent reported. There's some Vineland's versions. This is a validated measure, a validated survey that are clinician or doctor collected. So this is the parent reported version. For this, we have 62 people who have filled out the survey. We're giving a summary here. So yes, so for the 62 people, each particular person is shown with 1 dot. So it's not necessarily showing that person over time. It's showing the most recent Vineland piece of information that we have. We do ask for this every year. So there is a limitation to what I'm showing here right now. Although we do have every single Vineland, again, within our registry, researchers are absolutely invited to analyze and use this in their research. But for everybody new to looking at this Vineland summary, across the bottom is the actual age of the participant, the actual age at the time that the survey was filled out for every one of the Vineland graphs I'm going to show. And then across the left-hand side here, you're seeing the level of age in years alignment by the questions. So the questions are being answered. Can the person do this or that? Do they do this or that? And then we can align an average. What the researchers have done who created the survey is they've aligned the scores for each body system into an average for the general population. So that's this alignment here. So based on the person's answers, where do they fall in the functioning here, in the functioning along this axis? So in general, this cross-sectional, meaning at this one time point, we are seeing for expressive language development that the majority of people over the age of 4, 75%, are able to use at least single words or using language as they get older. So here you're seeing for this particular graph, this is like a developmental curve that we've created. Here in this dotted line, you see the level at which, in general, people are using single words, the age at which people are using single words to request. And we've created this line that kind of follows the data, the information. And in general, it's going up, and it suggests that there is a gaining of skills in this space. There's several kids here, several children here at the age of 9, 10, 6, that as they grow up, we'll see how this curve changes. So we don't want to say that this is the limitation or this is the end. No, this is just the beginning of what we're starting to understand in this community. And the more participation over time and the more we're able to gain, the more we're obviously able to give back to families about how this might change, how someone might grow. And if we are able to get more and more pieces of information from the same person, we eventually, or researchers definitely, are able to create individual lines and connections as to how that person aged over time. So now a domain or another area of the survey of the Vineland is the personal care skills. So here you're seeing at the lower dotted line is the age and the general population where a person feeds themselves with a fork and spoon, and the age at which a person usually is dressing themselves. So again, the summary from this particular chart is that 80% of people are likely to be feeding themselves at the age of 4 and older. So here you see that above this line, the majority of people are feeding themselves 4 and older. Again, this line is going up in the upwards direction, suggesting gaining of skills. Now for social development, the lower line is showing making eye contact during social interactions, and this upper line above the age of 5, choosing good friends. And so what we're finding from this is 67%, so almost 70%, or 7 out of 10 people, are likely to be making eye contact during social interactions. And then for gross motor development, so this is, how people are moving, particularly this lower line is walking without help or hopping and jumping. We're seeing truly most people are above this lower line. Most people are likely to be walking around the age of 4 and older, with quite a bit of spread across these different people's abilities or these different children's abilities. But in general, again, these are moving in the upwards direction. So for the last survey, the last survey data that I'm going to cover is the child behavioral checklist. This is a type of survey that we only are able to give to people 18 and under. It's just how the survey was created. And there's 2 different versions of the survey. So the first survey that's shown, because of age differences, is for people ages 1.5 to 5. So that's 18 of the children that we have in our registry have completed this survey under the age of 5. And what are the top behavioral and emotional concerns coming up in the community, which are scared to attempt new things. They might be a little more attached to mom or dad or family members. Clingy is the word that's being used here. They desire more frequent attention. These two may be linked or related to each other. And then specific fears around animals, places, or situations. As someone gets older, so this is the ages 6 to 18 range, obviously the questions change because the behavioral may change as someone gets older. The demands more frequent attention seems to be the same potentially within these 2 groups. So we have a larger number of people over the age of 6, so 42 people here. And then you see hyperactive behavior popping up, frequently distracted, and more of the obsessions or obsessive behavior coming out within the older ages. So in summary, as mentioned, the common issues that we're finding is intellectual disability, developmental delay, language delay or impairment. We have common low muscle tone and coordination challenges within the community, vision issues, and gastrointestinal issues. Some of the other challenges within the MED13L community is the short stature, failure to thrive, autism, some seizures, orthopedic issues, as well as scared to attempt new things or needing more attention from their loved ones, and adaptive behavioral challenges in general. So this is my final slide. Thank you so much for bearing with me. I know that there have been many talks and it's been a lot of information sharing, I'm sure, from the wonderful other speakers that have participated. We just to say are a long-term ongoing research cohort. We're, as mentioned, celebrating 15 years this year. We're already making research plans for next year and the upcoming years. Our lead principal investigators is Dr. Wendy Chung out of Boston Children's Hospital and Dr. Cora Taylor out of the Geisinger Health System. But we are funded through the Simons Foundation nonprofit under the Simons Foundation Autism Research Initiative. We are international, and we think this is incredibly powerful in multi-languages to be collecting and engaging with the community. As well as we work with a community advisory committee. So we do have parents that serve on a 2-year board that give us feedback on various different research efforts that we have, but we do tap into our patient and parent community to really help guide many of our research efforts, as well as a matching biobank. So the researchers that come get the biological specimens can match the biological, like what's going on in the cell line or the biological sample with the information that the family has shared about the medical history of the person. We prioritize sharing back in an easy to understand way and trying to make it as multi-language as possible. We're making more efforts around our registry reports in the upcoming year to make them into multiple languages ourselves, as well as we collect this information with the utmost data standards in place. So we do not share anybody's location, personal information, emails, anything like that. And with the external researchers, they get de-identified information, as well as we follow GDPR compliance. So thank you so much. If there are any questions today, of course, I'll be happy to address any questions in person now. But any future upcoming questions can be directed to this coordinator email. I help manage this email address along with many of my colleagues, as well as follow upcoming information with our Facebook, X, YouTube channels that our communications team manages and tries to keep up to date. So thank you so much.